Hello, age disruptors. Today, I am recording this podcast with a live studio audience. All of you attending this recording are members of the Hack My Age VIP program. And part of being in this exclusive club is the ability to dial in and watch the interviews as they are recorded and ask your own questions, not just mine. And if you want to be a part of this amazing community, go to patreon.com/hack my age and sign up not only for these cool interviews, but free breathwork and meditation classes, private consultations, and so much more. So today's guest is back for a second time on the show, and she is one of my favorite guests, as many other people will agree with. She's a regenerative and anti-aging doctor who has a whole list of qualifications, and she's one of the most well-trained doctors on hormones. She's incredibly intelligent, and it's going to help us understand our own hormones and clear the confusion on hormone replacement therapy. I'm talking about the one and only Dr. Elizabeth Yurth, she's been helping hundreds of women just like us solve joint pain, menopause problems, and inflammaging, and just get back to our old balanced and energetic selves. And Dr. Yurth is trained in sports and spine orthopedics, functional and regenerative medicine, and even cellular medicine. And after a really long career in orthopedics, Dr. Yurth decided it was time to move her practice forward to the next level. And in 2006, she co-founded the Boulder Longevity Institute. And I'm dying to visit this place. I will one day. And there they specialize in advanced research-based longevity medicine that has treatments like bioidentical hormone replacement therapy, yes please, regenerative orthopedic procedures, yes please, and regenerative peptide therapy, oh yes, we want some of that too, and next generation regenerative services. It sounds like a sci-fi movie. So what makes Dr. Yurth someone who we should be listening to? Well, she is double board certified in physical medicine and rehabilitation and anti-aging regenerative medicine. And although she doesn't look like it, she has a long history as a specialist in sports, spine, and regenerative medicine. And that includes a Stanford affiliate fellowship in sports and spine medicine and a dual fellowship. It's not easy to get these fellowships, you guys. She's got a dual one in anti-aging and regenerative medicine and anti-aging, regenerative, and functional medicine through the American Academy of Anti-Aging Medicine. And if all you understood from all of this were the words regeneration and anti-aging, you got it. That's good enough. So you think she's qualified? Yes, I really think so. But hang on, we're not done yet. She's been selected as one of the 25 Mastermind Physicians Fellows in SSRP. That's the Seed Scientific Research and Performance. This means it allows her to stay abreast and teach others in this growing field of cellular medicine. So yay, we can have more people like her on the planet. And the cool thing for athletic older people is that she's like me, an active athlete herself. So she totally gets us. And Dr. Yurth lives and breathes active human beings who want to keep moving in their 80s and 90s. Heck, why not their hundreds? Because she lives in the health mecca called Boulder, Colorado. And so now, before I introduce this amazing biohacking superhuman, I must read this disclaimer. All information and content and material of this interview is for informational purposes only and is not intended to serve as a substitute for consultation, diagnosis, and/or medical treatment of a qualified physician or healthcare provider. Dr. Yurth will not be answering questions related to your specific medical care or personal medical decisions. So if you need someone like Dr. Yurth, you just call her directly, the Boulder Longevity Institute. So before we start, I want to also thank my biohacking bestie, Natalie Nidham, for introducing us. And if you don't know Natalie, then you got to check out her amazing podcast too. You can find her at Biohacking Superhuman Performance on Apple Podcast and Spotify. So now, without further ado, let's meet Dr. Yurth. Welcome.
Thank you, Zora. Thanks for having me and for that long, amazing intro. I appreciate it. I know it
It's
does
all
make me
true.
sound.
It's all true.
Yeah, I so appreciate you having me on and talking about this topic, which is kind of near to dear, I guess, to all of us, and hopefully share it with those of you who I know a lot of times people start caring about this stuff in their 40s, 50s, 60s, And hopefully those of you who are doing that will share some of this info with your kids or younger people you work with or things like that, because I think it's info that needs to get out there and you need to start thinking about even, much, much earlier. Like all of us, I think would have wished we had the info we have now when we were in our 20s and 30s, right? Because
Mhm.
probably some of the damage done would have been avoided. So thanks for spreading the word.
Oh, absolutely. Couldn't do it without you. And today we're really going to take a deep dive into menopause and hormones. And like you said, I wish I knew these things earlier in life because, well, damage control would be much easier. And last time we met, if you guys haven't heard this podcast, you have got to go back and listen to it. We talked about the regenerative medicine and joint issues and hips and knees and shoulders. And what really blew my mind was how you explained that these orthopedic issues come from a disease state. And they're very much related to our hormones, which I just didn't even occur to me. And this is not just because we have some unavoidable deterioration that comes with aging, and I never would have connected these dots, so which are so important for women who are in premenopause and in menopause, and we just think we're getting our aches and pains from wear and tear. And let's do a real quick recap on how these hormones are affecting our joints, and then let's just jump into the menopause after that.
Sure. So I think that one of the things everybody needs to understand, and certainly your listeners are better at this than most people, but is that really all of those diseases of aging, be it dementia, be it cardiovascular disease, be it hypertension, metabolic disease, all of those things that we see, infections that we see increase as we age, are all related to disruptions in kind of our immune systems and dysregulation in our bodies. And so people have kind of started to think about all these diseases as, hey, maybe the one link is that our cells are aging, our immune systems are aging, and we can't fight off these diseases. But our aches and pains, our back pain and our knee pain have sort of been not thought of in that realm. We always sort of think of those more as just like wearing out your tires on your car, that it simply is too much wear and then you've got to change them out. And that's really not the case. Osteoarthritis, a wear and tear type of arthritis, is back pain. Reason they increase as we age is the same reason all these other diseases do, and that these are disruptions in our immune systems, in our aging processes. So how do we avoid that? How do we keep our immune systems healthier? How do we get our cells so that they can regenerate? How do we get rid of bad cells that are doing damage? Your listeners all know about senescent cells. Well, we have senescent cartilage cells too, right? The same thing that's happening in your heart, in your brain, is happening in your joints. And unfortunately, if you think about people, how do we treat an arthritic knee? We go in there and we sort of scrape out we trim off the bad cartilage, and we call it a cleanup of the arthritic joint. And I always tell people that's akin to going to my Alzheimer's patient and go, oh, let me just go clean out those bad parts of your brain, right?
Yeah.
It's not going to work. In fact, I've just made them worse because I just removed parts of their brain. The same thing happens in joints, right? As soon as you start trimming away the joint, the typical orthopedic cleanup, that you've actually done more damage. You've taken away parts of the joint. So we have to start thinking about this disease the same way you guys are thinking about other diseases, and getting the immune system healthy. So how do we, what is the, first and foremost to that in my mind, obviously diet and exercise are, always going to come up first. And that's kind of a given. So we won't spend too much time on that. You guys know that if we're never going to undo anything if you just want to eat, sugar all day long, but, and sleep and not exercise, but we can help. And and we do know that one of the things that happens is as our hormones decline, our immune systems decline. So every one of our hormones plays a very vital role in our immune function. And that's testosterone, estrogen, progesterone, thyroid hormones, cortisol, so adrenal hormones. All of those hormones are vital. And so to say, well, it's okay to just get old, well, and that's what's supposed to happen is our hormones decline. Well, the problem is that without the hormonal support, can you really get the immune support you need to protect your health? And the answer is, in my mind, probably not. You have to have all those hormones and you have to have them balanced. And it's really all of them. I mean, it's not really just saying, okay, you just need estrogen, you're a woman. It's all of them. So that's so the first, just to kind of the first caveat you have to remember is that this is an age-related disease. Joint pain, back pain is an age-related disease, just like all those other diseases you guys are learning about and reading about, right? And so don't think about it any differently. Every one of them is part of inflammation. It's chronic inflammation due to a disruption in the immune system. I'm lecturing this weekend at Peptide World Conference with Seed Scientific Research Performance, and I'm lecturing on exactly that, on the immune system aging, and how that is probably the cause of all these diseases, and joint disease is the same thing. So that's sort of my long diatribe of that. Number one, learn that joint pain, back pain are the same as all those other diseases of aging, and so you have to prevent aging to prevent them. And number two, in my mind, that's very difficult to do. Not impossible, maybe, but very difficult to do without using hormones as well.
Yeah, this is the interesting point I want to bring up because so many women I talk to either don't know anything about their hormones. I knew very little even up till just recently because well everything seemed to be functioning fine and plodding along until you go, well, I know I'll hit menopause one day and I better get on it. And so I've been talking and researching a lot about bioidentical hormones, hormone replacement therapy, and you get this uh I guess the response I get very often is, well, oh, you shouldn't do that, or that's going to give you cancer, or that's not good, that's bad, or I heard this study. And so I think there's a lot of misinformation out there.
Mhm.
And so I want to ask you then, well, what is the risk, because people worried about the risk of taking hormones, what is the risk of not taking hormones or hormone replacement therapy? And now we're just assuming, again, I just want as a caveat to everybody listening is, of course, we're talking about optimized nutrition, sleep,
Right.
movement, and stress management. Of course, that is fundamental. You can't just pop like an estrogen pill and think everything's gonna be fine. But just generally, what is the risk if we don't consider our hormones in our as we age?
Yeah, I think you kind of brought two questions. And number one is, what are the risks of not doing hormones? And then what are the risks of doing hormones? Because the big thing I still hear over and over and over again is, well, I shouldn't do hormones. Hormones cause cancer. And that is such an unfortunate myth, and it was really based on the Women's Health Initiative study, which pulled everybody off their hormones because it was so dramatic that these hormones were causing cancer. And what nobody followed up was years later when the authors of that study said it was completely misinterpreted, and that's not right. And we've had subsequent studies over and over again, much larger studies that support that no, hormones do not cause cancer. um, and yet that the Women's Health Initiative still sticks. It's still sort of stuck in everybody's mind. It was that dramatic of a publicity, and and I can only think it would have been worse if it would have been released today, where we have social media. At least back then we didn't have social media, but everybody read the newspapers and magazines and saw these studies and said, "Oh my God, I can't take hormones." Well, there was a lot of problems with that study, and too numerous to mention. We actually have, if you guys go to our BLI.academy, so our Human Optimization Academy site, we actually have a nice talk up there, just kind of explaining that all, like what was wrong with that study, and so to what where did that misconception happen? But there were a lot of problems with it, and subsequently really disproven. So that's number one. But I would also say that, do I think that appropriately done hormones can be linked to cancer? I do. And that has a lot to do with understanding how we metabolize the hormones. So based on your genetics, your cytochrome pathways, how you metabolize any drugs, hormones are the same thing. And some people are going to basically metabolize them down very safe pathways, and they'll be great no matter how much estrogen you gave them. And other people, maybe not so much. So when you look at giving estrogens, for instance, estradiol, there's three different estrogens. There's estrone, estradiol, and estriol. Understand those as estrone has a 1 in it, so that's E1. Estradiol, di 2, so that's E2, and estriol, tri E3. We make tons of estriol, E3, when we're pregnant. It's very, very protective. So it's one of the reasons the more pregnancies you've had, the less your risk of cancer is, breast cancer is because E3 has such a protective influence on breast and ovarian tissue. And so E3 is a very protective estrogen. We make massive amounts when we're pregnant. We don't make so much at other times in our life, but we make some. Some of the estradiol we make converts into estriol. And then E2, estradiol, is the main hormone we make when we're younger. And it can convert, it can stay as estradiol, which is great. It can convert down into estrone or E1. As we get older, we start making more estrone. So less E2, less E3, more estrone. Not necessarily bad, but estrone can metabolize, again, based on your environment, based on your genetic, based on your diets, based on your exercise, down 3 different pathways. So the first pathway it can go down is a great pathway. It goes down to a pathway called 2-hydroxyestrone. That's a really protective estrogen. And if you can go a little further than that, it can turn into an even better estrogen called 2-methoxy. So if all's perfect and all my estrogen goes down this great pathway, I'm probably golden. But there's 2 other pathways. There's a 4-hydroxyestrone pathway. And the 4-hydroxyestrone is not a good player. So if my cytochromes are such, my genetics are such, or environmental influences, for instance, a lot of the estrogens that we get exposed to will link down this 4-hydroxyestrone pathway. 4-hydroxyestrone can become a very damaging free radical. And it's probably the link in men to prostate cancer and in women a lot to breast cancer. So if you're unlucky enough to have those genetics, or environmentally you're eating tons of bad things and things like that, you're going to drive that pathway more. Or sometimes certain drugs will have blocked other pathways, and so will drive that pathway. So there's certain medications that will sometimes compete with pathways, because the medications you're taking all have to go down these pathways too. So if you're going down this 4-hydroxy, if I put all of these women on estrogen, and you happen to be somebody who every ounce of estrogen I just gave you turned into 4-hydroxyestrone, then I probably am increasing your link to cancer, right? Then the last pathway is 16-hydroxy, and 16 is kind of a medium player. It's great for bones. It has a nice estrogenic effect, but it's a powerful estrogen too. So you don't want too much going down that pathway, a little bit. So we want a little into the 16, not very much into the 4, and a whole lot going down to the 2 pathway. So understanding pathways is kind of critical, right? And so how many doctors do that? If you go to a doctor and they put you on estrogen, how many people actually follow the pathways?
Mhm.
Not a lot. The issue is the only way to really follow the pathways is by doing urine metabolite testing. So you have to do, and we love what's called the Dutch test. It stands for a dried urine test of complete hormones, because you guys can just even self-order this test. And you pee on a little strip of paper 4 times through the day. So it's the equivalent of collecting your urine for 24 hours, which is much more tedious. That's what we used to have to do. And then it tells us exactly how you're metabolizing things. And so I just saw a 25-year-old yesterday in my practice, and her mom sent her to me because there was such a strong cancer history in that family. And she wanted to see early on, which is great, right? At 25, is she driving even her own estrogens down this 4-hydroxy pathway? And indeed she was. She had a very, very strong metabolic pathway down the 4-hydroxy. So it made sense that her mom got breast cancer, and her aunt got breast cancer, and her grandmother got breast cancer, because that was the genetics to drive down that pathway. So I would put the caveat that that's a useful piece of information for everybody, right? To know,
Absolutely.
how are you metabolizing these things? So then what do you
So
do about it? Right?
yes, so it's amazing because normally people go to the doctor and they just take your blood test and see how much estrogen you'd have in your blood, or that's everything's blood work. And so
Right.
what you're saying is that that's not a clear picture of what's going on. That's
Right.
your what's how much is in your blood, but how is it converting? And these pathways, I don't know if my traditional doctor would know anything about this.
Yeah.
So this is super important information to know what's happening. Now, would you say that this is important just if you have a history of certain diseases, or
No, I
in
mean,
a
it's important for everybody to know that,
Mhm.
right? Because this 4-hydroxyestrone is such a bad player. And so it's really important. And it's a bad player, probably not in just breast cancer but probably in some other diseases. It creates an oxidative free radical. It's a DNA damager. So we
Mhm.
know DNA damage, the oxidative damage is bad, right? We're all trying to avoid this oxidative stress. So if I'm feeding down this pathway, I am creating chronic DNA damage. That's going to be linked to a host of other diseases as well. So other types of cancers and other type of metabolic diseases. So it's linked to other diseases as well. So I think it's not just if you have this family history of breast cancer, um, because even if because your genetic pathway may be such that you're fine, but you're taking a drug or have an environmental influence, which unfortunately we all have a lot worse environmental influences anymore, that is still driving this pathway. So you still need to know that. So, and lots of times, if you're in your 50s, sometimes your estrogens are so low that doing this urine test is worthless. You don't even have enough estrogen. But if I put you on estrogen, I need to know it. So we do the Dutch test usually after we've started the hormones for a little while to see what's happening. How are we driving things? Or in my younger women, I'll do it who I'm not going to put on hormones, but I want to know how they're metabolizing hormones. I mean, even progesterone can go down two different pathways. One's a really strong, potent progesterone, and one is a really weak progesterone. And so some of these women who have normal progesterone blood tests, but they have a lot of symptoms of low progesterone. They're irritable, they're anxious, they can't sleep well, they have aches and pains. Or in your younger women, they have horrible PMS. I have a daughter who has you just have to stay away from my sons are always like, my God, whoever marries her is just in trouble, because literally, like right before she's going to have her period, it's like, oh my God, all hell breaks loose. You just stay out of her way, and so she's somebody who if I do blood tests on her, her progesterone levels actually don't look bad, but neurometabolite testing, she does takes that progesterone down a very weak pathway. So sometimes even those young women who have these kind of symptoms, you put them on a little progesterone, and particularly at that end of their cycle when progesterone's really dropped down, and they're like different people.
Mhm.
Um,
It's quite amazing then. So you would then with your clients, you would generally give them the Dutch test after you started some kind of hormonal therapy or before?
Yeah, we used to just do it before, but we found that so many women, women lose their hormones at different stages. There's some 50-year-old women who still have great hormones, but some 50-year-old women or even 40-year-old women who are just bottomed out. So if I'm trying to test urine metabolites, and everything's in these minuscule amounts, making any sense of it is impossible. It's like, the dial moves this far, so I can't really tell. So what we'll do in those women is, so if we'll do a serum test first, right? A blood test first, and if every hormone's low, then we just put them on the hormones, and then 6 months later, 3 months later, we'll do the Dutch test. So now we know what we've done to them. And if I see if you see that you're driving down this pathway, we don't want to wait too long. We don't wait 3 years and say, oh my God, that wasn't good. So we want to do
That's
that early on enough, right?
that's a great approach because the Dutch test is expensive. Or I mean, it's
Expensive, right?
around
I think it's like
$500. No,
it's
four
like
or
three
five hundred.
ninety nine.
Okay.
Yeah, I think it's like, yeah.
Plus the
And lots of
doctor's
times,
visit, so yeah, it
yeah,
can.
yeah, yeah, and this woman I saw yesterday who's this 26-year-old, whose mom, if like if you can find a doctor who literally will just, I mean, your listeners can listen to this and understand a lot about the Dutch test, quite frankly. I mean, so we're always happy to do a little hour consult and just go over Dutch tests with people just to help you because there's a lot of information there that's really fun to learn. But even looking at those things with that knowledge, right? So and I'll tell you, there's usually a coupon online that you can get $50 off this test. So even looking at that, if you just wanted to see, where are my hormones going, or which pathways, because it's such a nicely done little test that honestly it's not hard to interpret. You've got these little wheels with,
Yeah.
this is a green pathway, this is a red pathway. So it's really, so even, even from that realm, and again, we see people all over the world, and we'll do that where we just sit down with them and just kind of go through a Dutch and help them interpret it. But so that's something pretty simple to do even on your own if your doctor doesn't, if you just have no ability for anybody to go through it with you. It's something that you could literally buy the test. It's a urine test. You send it in, they send you the result.
It's very
Yeah.
detailed, I have to say, and it's overwhelming. I think for me, it was
Yeah,
great to
it
just.
that's probably the biggest problem. But if you even if you just looked at those few things, it can be helpful.
Yeah, no,
So
and actually doctors who do usually give the Dutch test, as I understand, is they're qualified. You have to go through some training to understand even how to interpret them and
yeah,
be able
yeah,
to then
to
diagnose.
to everything, right?
Yeah, so I think it's really important people understand that. So I'm wondering then, so with the clients that you say, oh, I think it's a great approach actually, just because you go, okay, well now we can see what's happening to the hormones that we're giving you. But I'm assuming that these are people coming into you already with signs and symptoms of menopause. We're talking about hot flashes and not able to sleep and mood swings and joint pain or everything else that comes with menopause. So what would you say to someone who's like me, who everything's fine, I just want to prevent, and I've got a history of breast cancer with my mother died of breast cancer, so that's why I went down this Dutch pathway. I was like,
Yeah.
okay, let's see, because I don't want to be messing around with hormones, and I gotta get it right. So but at the same time, so my doctor put me on the Dutch test before to see, because part of me was like, well, what if I'm not really entering menopause yet? What if my hormones are fine? So
Right.
how would you approach someone like that, where everything apparently feels fine, but I'm 51, so you're like,
Right.
you got to be losing something.
Right. So I think that the key is that a lot of damage is being done, in that period, what we call sort of perimenopause. So you're still having periods, and some women we never even get a symptom from menopause, right? So to say the only sign they're in menopause is their period stops. Honestly, is so they have no other symptoms. Other women have horrible symptoms, and probably it depends on kind of how your hormones are dropping. Are they sort of dropping in a more balanced fashion, or are you becoming really estrogen dominant, no progesterone? So so there's going to be a lot of people, and I would equate this to any other disease process, is that you probably should, as we were talking about, treat before you necessarily symptomatic. I mean, there's no 50-year-old that I see anyway that has normal testosterone. So is damage being done because you don't have testosterone? Yes. Most, not all, but most women in their starting at 35 have low testosterone, have low progesterone, are starting to become estrogen dominant. Is there's issues associated with it? Yeah, there's injuries that are going to be associated with that. There's damage to the brain that's going to be associated with that. So estrogen dominance without progesterone backing it is going to be more at a risk for cancers. And so I think there's a lot of damage being done from an early age, and it's why we're really trying to advocate, should people kind of know this stuff earlier and potentially do some adjuncts. And sometimes that's very minimal things. It's using a tiny bit of testosterone and a tiny bit of progesterone. Estrogen oftentimes doesn't need to be replaced, in my mind, for a long time, because estrogen's the last thing to go, right? And so people always think of estrogen as the main hormone, but it's the last thing to go. So
Mhm.
honestly, what happens is you get into estrogen dominant state, you know, much, much earlier. So so now you have all this estrogen stimulation going on, which is why, you have more fat cells and your breasts get bigger, and then, women have bigger bellies. It's because they're in this estrogen dominant state. I always tell people to think about like those fertility statues, right? Big old huge bellies and big old huge breasts. That's that estrogen dominant sort of state. So
Yeah.
so I think that, like all diseases, the key is that starting earlier is probably, or being aware of things earlier is probably better. And androgens, androgens start dropping very young. I mean, you will see very high androgens in sometimes 20-year-old women, except now they're all on birth control pills, what suppresses that. But but after that, and how important are androgens, testosterone and DHEA for women? So remember, our androgens, our testosterone comes from our adrenal glands. We don't have testicles, so most of it comes from our adrenal glands. Our adrenal glands make DHEA, which you guys are probably pretty aware of, and then that converts into testosterone. That's where most of our testosterone comes from. So what happens if I'm stressed? What do my adrenal glands do? They stop producing much DHEA. They produce tons of cortisol. If I have no DHEA, I have no testosterone. So now I'm in this really cortisol, no testosterone. What's happening? I'm getting in a breakdown state. And so, and how many people can say they're not living stressful lives? I mean, that's almost impossible in this world. All this
Exactly.
stuff, meditation, everything's helpful there. But so I think that, so much could be prevented in terms of joint loss, brain loss, bone loss, hair loss, skin loss, if people started and looking at this stuff, not when they're, saying, hey, something's starting to change at 35, not at 51. There's no
You
way
know,
your hormones, maybe you don't need to be treated, but maybe a little bit helps.
I have a 38-year-old client who looked under the hood with the Dutch test. She was doing great. She actually was so
Yeah.
happy with the training I've given her, happy in her body. Everything's
Right.
fantastic. Got her to a great place. And she's like, I want to start learning about my hormones. And so we recommended, let's do a Dutch test. I mean, if you want to take a deep dive,
Right.
she was horrified. She couldn't believe it. And so I know it's not only me, who's just going to go, wow, my testosterone's gone, but I'm 51, but hers at that young age.
Yeah.
And it has a lot to do with cortisol. The cortisol is
Yeah.
actually completely gone because it was so high.
So it's just so, yeah.
Yeah.
Yeah, and you see that a lot, right? All these
Yeah.
people, so that's one of the cool things about the Dutch test too, is it gives you this kind of cortisol, 4-point cortisol. You look at cortisol stores and how you're using cortisol, and so many people are just in a mess. They're not sleeping right, and they're stressed, and they're not using your meditation stuff and all those kinds of things, and it's hard. I mean, it's hard not to be in that state. So
Yeah.
can counter that a little bit. Like we can work on the stress, we can work on lowering cortisol and all those things. And then we can counter that with sometimes giving just DHEA maybe, right? Because that might
Mhm.
boost them enough to get a little testosterone. Maybe you don't even need to use testosterone. You can just use DHEA at that stage, right?
Yeah. Actually, what her doctor had her do, actually, it was no hormones at all except cortisol, because to try to jumpstart her
To get a drink.
cortisol, she
Hmm.
does have to take testosterone cream evidently for the rest of her life, because she says that doesn't come back at her age. She's 38, so
Yeah,
she can jumpstart still stuff. But when we
right,
get to 50, our 50s, I don't know how possible is it to jumpstart your own,
right, right.
and that's maybe
Right, there's
why.
just nothing there, right? I mean, if your ovaries aren't functioning, if you're, or if you burn out your adrenal glands, then obviously, and I'm a big advocate that, when people talk about, okay, I'm doing all these things to try and, get these hormones boosted up. Sometimes, and it's like her doctor giving her a little cortisol, right? Sometimes just give them the replacement uh, to
Yeah.
try and help out, right? And then sometimes
Yeah.
once you get people into a little better state, then you can work with them a little bit. Sometimes you can actually, as they get healthier, you can start dropping some of these things down too.
Yeah, well, it was very interesting to see, because she showed me her blood work in the end was just a little bit of cortisol jump started, like all the
Everything's
estrogen and
right,
progesterone just
improved.
went straight up. I was thinking,
Hmm.
wow, she didn't even give you progesterone. She just took the
Right.
master regulator cortisol, and that just somehow
Yeah.
increased all
Yeah,
the
it's
other
something called a
ones.
progesterone steal. So when you can take progesterone to utilize it down kind of cortisol, and so when we're really stressed and we completely run out of cortisol, we actually start stealing our progesterone to make cortisol, and so it's called a progesterone steal. And so that once you're out of cortisol, you're right, you start depleting. Your testosterone goes down because your adrenal glands aren't functioning to make DHEA, but you also start this progesterone steal pathway, and that's one of the things that happens in a lot of these overtrained athletes because they bottomed out their cortisol and now they get rid of all their progesterone and now they're not sleeping and they start losing bone and all these things. And so it's one of the pieces of this very high stress or athletic burnout is, and so overtraining, just like mental stress, can do the same thing too.
Oh, that's interesting. So let's get back to that question then. So, what I understood from you as well is that hormones need to be in balance. And if they're too high or if they're out of that balance, then that's not a good thing. And if they're too low, also out of balance, then that's not a good thing. So, what are the risks if somebody, like, and you've already said some of these things as well. If someone doesn't consider, if they say, you know what, I'm just going to go all natural, I'm just going to try to support my hormones naturally, and they ignore all of it. What risks are they putting themselves at by just putting their head in the sand?
Yeah, and that's huge. So if you look at the number one sort of killers of women, number one is cardiovascular disease. So what is one of the very important things for our cardiovascular system is actually estrogen. So estrogen has huge cardiovascular benefits. It's one of the reasons, if you look, men have more cardiovascular disease than women until women get older. And so estrogen has a huge protective effect. It also helps cholesterol management. So you'll have larger, fluffier particles, safer particles with estrogen. So if you're scared of cancer, and I hope I've alleviated that fear, but even if you're still like, no, I'm just too afraid of hormones and cancer, well, then you should be more afraid of the fact that your risk of dying of cardiovascular disease is substantially higher if you're not on hormones. You know, Number 2 is the other big thing is when you look at bone, and you can take all the vitamin D you want, and calcium, magnesium, and all those things. But the main stay for bone is hormones, and that actually helps the metabolism of calcium. So, and it's not just estrogen. Estrogen gets all the credit. Estrogen, testosterone, progesterone are all critical for bone building. So all three of those hormones are critical for bone building. Estrogen, people always say, oh, it's estrogen. Estrogen actually helps maintain bone, but testosterone is more anabolic, really, to build bone, to get bone thicker and denser. And so you need testosterone on board to help bone. If you look at really older women, then the huge risk associated with a fall and a fracture. And in fact, if you're over 70 and you fall and fracture your hip, your likelihood of ever getting back to the lifestyle you were at before is minuscule. People do not come back from those things. And as you get older, your risk of dying from those things is considerably higher, partly because you get more sedentary. My own mom, who, passed away last year, she fell, she was, just 96, so she was old, but she fell, she broke her pelvis. And, and 3 months later, she died because she really could just never move again. I mean, she became pretty much wheelchair bound, and even, getting her to the bathroom and dress was impossible. So,
Yeah. I
so
just did a conference, an international conference in Spain, and that one of my statistics that I remember I pulled out a study was 50% of the people with hip fractures die within 6 months, I believe
yeah,
it was.
it's dramatic. I
That's
mean, it's
dramatic.
dramatic. I mean, it's dramatic. And people don't think about that. They think, oh, I fractured my hip, it'll fix it. No. I mean, you do not do well with a hip fracture. And if you do not have hormones on board, nothing else you're going to do is going to maintain bone. I can tell you, I don't care how much stuff you take to protect your bone. If your
Mhm.
hormones are not in order, then that's not going to happen.
Yeah,
So,
just
so
before I just out of my head, in case anybody's following this and go, oh my God, I had a hip fracture at 35. It's over 65. It was people over
yeah,
65.
right,
Like
right. It's as
that
you get
caveat.
older, right?
Yeah.
Yeah. So if you're 30 and you fall off your bike and you fracture
Yeah.
your hip, you're likely to recover and do fine from that.
Yeah.
These are more osteoporotic fractures. These are fractures that are induced, because your bone density is so low. And if these these people fracture their hips and their spines. I see it all the time. Somebody literally bent over to brush their teeth and their spine fractures. So you get these compression fractures in the spine, and then yes, you see these old women who are just all hunched over, right, like that. That's from wedge compression fractures of all the thoracic vertebrae. The X-rays are astounding. I mean, astounding. And they have chronic back pain, and and don't rely on your orthopedic doctor to ever, if you go in with a wrist fracture or a hip fracture or a spine fracture, to ever check your bone density and recommend hormones. It just doesn't happen. They stick a big pin in your hip, but nobody ever addresses the root cause. And that's really, criminal in my mind. I mean, that we're now just sending these people back out the door and they fracture something else or they die from that fracture. So cardiovascular disease, bone, and then in the brain. So we know that hormones are also very, very neuroprotective. Progesterone has a very, very neuroprotective effect on our brain. It helps us sleep. It's very restorative, but the brain directly has receptors. So, it has a direct effect on the brain as well. So we know that all of us fear losing our brains, and we don't have a lot of, we can tell you, yeah, there's so many things you can do, but one of the main things you need to do is keep hormones up to protect your brain too.
Mm.
So when you look at that list, cancer kind of falls down quite a bit. It's not even in the top five of those. Actually, it is. I think it's number five. But of the things and that we can prevent with simply using simple, well done hormone replacement. And as I
Yeah.
said, I think hormone replacement done well, you can actually reduce the risk of cancer, not increase the risk of cancer. So that should really go down the wayside. The other question I get so often from patients is when I put them on hormones, is, well, do I have to stay on these forever? And I'm like, well, I guess if we, find the fountain of youth and you can drink it and become 20 again, maybe not. But otherwise, unfortunately, you are aging. So it's not like all of a sudden your ovaries wake back up. As you said, like your patient, your 38-year-old, who they gave her a little cortisol and yeah, things perked back up. But in general, we're declining, right? And so to say, oh, okay, you're fine now. I've given you all the hormones you need and you're set for life, is not going to happen. And when I stop those hormones, you're going to go back to your base level, which is going to be lower because you're older, and you're going to start at that stage. At least we boosted you up, so that's great, right? So you've made it back up to here. So now when you start to decline, it's going to take you a little longer, but you're still going to decline. And so I always tell women, I go, well, I guess when you're ready to die, you can stop them, But other than that, you should probably plan on these or something that are going to just become a mainstay of your existence.
Yeah.
And,
This is
you know,
actually, it reminds me, I just interviewed Dr. Dale Bredesen, and
uh-huh,
he's all about Alzheimer's, and he's a neurodegenerative medicine doctor.
right,
And so he was amazing because part of his protocol, so his protocol in terms of reversing Alzheimer's, which he adamantly says you can 100%, there's a lot of things you have to do. It's not just one little thing.
right.
One of the part of the protocol was for women to look at their hormones and balance them out with bioidentical hormones. And he got the same question where the patient was saying, well, how long do I have to be on this or on this protocol, especially these hormones as well? And he says, well, as long as you want to feel good, as long
Yeah.
as you, because what he's noticed through the patients he's taken through the protocol, once they're feeling better and they can get their memory
Yeah,
back and they're feeling
right,
great,
exactly.
then they stop the protocol. They
Stop
don't,
doing it.
the diet goes down, the sleep goes down, the
Mhm.
exercise, the hormones and everything, they start to leave. And then they start to progress towards Alzheimer's again. So, the answer to that
Right,
question is, yeah, I loved his answer is as long as you want to start feel good,
right.
and you're
Yeah.
going to love your hormones when they come back.
Yeah,
Right.
yeah, I think that, I mean, that's a great answer, and, the whole Bredesen protocol is amazing because he is addressing things from a whole lot of aspects, um, and I'm glad to hear him say that because I actually didn't know he actually had in his protocol. I actually knew a lot of his stuff, but I didn't know he actually had hormones in there. So I'm really happy to hear them say that because I do think that that is such a big key that sometimes gets overlooked when we deal with our patients who are early Alzheimer's or mild cognitive impairment, and and we talk about hormones with them. The neurologists are always like, well, that's not going to make any difference, and it does. I mean, it does make a difference. So
Absolutely. So, what are your thoughts then? This is a question that a lot of women too are not aware of: is hormone replacement therapy traditional versus bioidenticals? And what is your opinion on the two? What if someone, should they be aware of the differences, ask their doctor about certain things, uh, other misconceptions about them?
oh, one of the big, and I think unfortunate misconceptions even within the functional medicine world is, is bioidentical estrogen different from estradiol that's prescription? And it's actually not. I mean,
Mm.
estrogen is estrogen. And so if I give you a prescription for estradiol, estrogel, for instance, it is the same thing as my bioidentical compounded estrogen. And unfortunately, I think because of that, it's created this divisiveness in the medical community where they're like, like where the regular docs hate the functional medicine docs who are, touting you have to be on bioidentical hormones when really honestly their own estrogen is the same thing we're prescribing. The difference is that I can use much more refined um, dosing, right? So I can dose it differently as opposed to the compounded or the non-compounded. But estrogen is estrogen. Estradiol is estradiol. It, there's no bioidentical estradiol versus normal estradiol. Estradiol is the same exact compound. Where the bioidentical becomes much more critical is in progesterone, because bioidentical progesterone is not Premarin, which is what's used in the pharmaceutical world as progesterone. So that's what's in your birth control pills. And that's what was, in the old, menopause medications. So basically, that Premarin is not at all progesterone. In fact, it doesn't fit in the progesterone receptor. It has, if you look at the two structures, they're different. They do not, it's made from pregnant mare urine. That's where it got its name, Premier and Premarin. So basically, it's
Wow.
made from
Got
these
it.
stress. They actually, it's horrible. And if nothing else from an ethical standpoint, they take these poor pregnant horses and they keep them in these little bins. So and and they collect their urine. They calf them and collect their urine, and that's where Premarin is made from. So it honestly is has a very different effect on our bodies, and it has a carcinogenic effect. And it's where, unfortunately, a lot of the studies, when you look at the studies and you look at what they use as hormone replacement, they used estrogen. Yes, that's probably the same, but Premarin is a bad player, and it causes drive even of the estrogens down different pathways. So that's where that difference lies, and that's where you really have to be careful. And then testosterone really isn't made in any kind of dosing. So there's testosterones for men, so there's testosterone gels, things like that. Again, they are testosterone cypionate, just like the testosterone we use in general. They really don't make them in the doses that we need for women, and so that's difficult. And then honestly, it's actually usually less expensive to get the compounded medications than it is like a prescription estradiol.
Huh.
The other piece of estrogen is estradiol only comes as estradiol. And sometimes I'll put women just on estradiol. But sometimes, particularly sometimes if they have a really high breast cancer history, or I just can't change their drive of pathways, I'll use a little bit of estriol. Remember, I said the estriol was a very protective estrogen. Sometimes it can have a few more, like women will get a little bit more breast tenderness and things like that. So be careful with it. But so sometimes you'll use you'll use a percentage where you'll use some E2 and some E3 mixed together. So it's a little bit, let's put a little bit of this, a little bit of this, so we can make sure these pathways are going the right direction. Because estriol actually does have such a protective effect. For a while, people advocated just using estriol, just use 100% estriol, but doesn't really convert well down into some of the more necessary pathways. So then they went to using percentages. And I think that works, but I think that sometimes you have to, so for instance, biased, which is the most frequently compounded bioidentical estrogen, is a combination of estradiol and estriol. That's why it's called biased. It's two estrogens, right? And for some women, that works great. That's probably the most go-to compounded estrogen. But for some women who are complaining when they're put on their bias by their functional medicine doctor of a lot of just side effects from it, sometimes you have to back down on the estriol.
Mm.
So that's where that kind of refinement really comes in, and understanding the metabolism of it. But
Yeah.
but I really do want people to be a little bit more aware, because I do think, that we have to sort of stop this divide that the traditional medicine doctors think all the functional medicine doctors are quacks. And part of that comes from this, well, hormones are hormones, because in one sense they are. So yes, bioidentical hormones are better. It's because of the progesterone, and it's because I can dose them appropriately. It's because I can refine the treatment. But estradiol is still estradiol. So I think that's confused even in the functional medicine doctor world, quite frankly.
Yeah, absolutely. No, and the experience I've heard of from other women are they never seem to get it right the first time. Like when you are trying to get your hormones balanced, the the signs and symptoms change until
Mhm.
and they seem to have to get it 2 or 3 times before they really find their formula.
Yeah.
So I want to ask people to
Yes.
please have patience
Yeah.
with their
I'm glad you
formulas.
said that, because I always tell people this is going to take us a little bit. Like I said, it's like a little more salt, a little bit. It's like tasting your soup in a sense. Nobody seems to react the same way. Like for me, hormones, I could dose them twice as high, half as I feel the same regardless. I kind of dose them based more on my labs, because I don't really feel like I have this dramatic change. And then I have women who literally, I make the tiniest little change, and so I have women who are just so sensitive to little changes. So it's very individualized, and sometimes that refinement is difficult to find, and people lose patience because they're like, oh my god, well, I'm not better now, you made me worse. And I'm like, stick with it. We just have to find this right combination, and that seems to be so different for different people, where they probably like where you probably, some people were always higher estrogen or lower estrogen as they were growing up. That's where their baseline is. And so you have to kind of find that. So I always tell people this is a little bit of a, of a, you're not instantly going to feel better. And I will tell you, for most women, testosterone makes them feel pretty instantly better. I mean, it seems to be the one thing not everybody, but one thing you can go to, and with a low amount, and they feel more energetic and stronger, and a lot of their pains go away, things like that. So it's one of those things that's a little bit easier. But estrogen and progesterone are always a lot of refinement.
Yeah, no, I hope people have patience with their doctor because sometimes I can imagine them, they come in not feeling great, but then they get
Yeah.
worse. And then they go, oh,
Right.
well, the doctor made
Right.
me worse. And you're like,
Yeah.
no, that's not that we're going to get there. So you have to have trust and faith in who you choose. So to give it a chance. What
Yeah,
I,
give it time and communicate. I mean, you have to have that communication, right? Not, when people come back and they go, "Well, I stopped everything because I didn't feel any better." I'm like, "Well, you could have called and we could have talked about that."
yeah, because sometimes going cold turkey from things can really mess you up
Right,
as well,
not
right?
be great either. You'll see a dramatic bone loss when people instantly, like, if you take your hormones, one of the biggest times for bone loss is right when hormones start dropping, so probably early, and, you get this big dramatic bone loss, and sometimes you'll see women on their bones, on their DEXA scan for bone density, do this big drop right around perimenopause, like in their 40s, they'll
Mm.
see this big drop. So
Yeah.
so just dropping your hormones dramatically like that too can cause a similar effect.
There's another test to get is to test your bone
Bone
density,
density.
especially as you get older.
Yeah.
One thing I want to ask you about the progesterone, because I did a great podcast interview with Dr. Michael Platt. And have you
Huh?
heard of him and his
Yes.
progesterone cream? And
Yes.
so he's, obviously trying to sell something, and he's got some great product, and I haven't tested it yet, but I just, it's there. But he says that progesterone cream is very different than the progesterone you take orally.
Mhm.
And so he says it's converts in the liver into something else that's not even progesterone. So what are your thoughts on a cream as opposed to an oral?
So, there's sometimes I use both together. The problem with progesterone cream is it doesn't appear to cross the blood-brain barrier as well. And so the metabolites you're talking about that come from the liver, well, those actually, some of those metabolites have some beneficial brain effect. So there appears to be less of a brain neuroprotective effect from, unless he has data to support otherwise, and I don't know if he has some research study that I'm not aware of, but the research does not support that the progesterone creams have as much of a neuroprotective effect, nor do they typically cause quite as much of the sort of nice relaxed state for sleep. So oftentimes, but they have some other benefits. So sometimes I'll use a combination in women where I'll use a little bit of orally, like 100 milligrams orally at night, and then I'll tack on because you do get a little bit different effect based on some of that metabolism. And so sometimes I'll use a combination of both. But and I'm not sure if he has data to talk about that, but I have not seen the data to support the transdermal progesterone's benefit to the brain. And it's one of the things I like about progesterone is some of its neuroprotective effects. So I'm still a fan of at least having some of it on board orally.
Mm.
But there may be data I'm not aware of.
Interesting. So are you not aware of what he mentioned about it being converting into something else in?
Yeah, I mean, there is some there, right? There's so when you take something orally versus transdermally, you get liver metabolism, right?
Yeah.
And so you can get some byproduct conversion, but some of that's actually good. So into these alpha pregnenolone and metabolites
Yeah.
can actually be beneficial to the brain that you don't get with the transdermal. So yes,
Mm,
it is metabolized differently. And what I'm saying is some of those metabolites may have some benefit to us that you
got it.
don't get with the transdermal. But the
Mm,
transdermal has a more direct, because you don't get the metabolism, has a more direct effect as progesterone. So that's where sometimes I think both are beneficial to people. Like you might get more
excellent.
joint effect from some of the transdermal.
That's interesting. Super interesting. So you don't want to replace one of them. Maybe you want to play around with both of them and see which benefits you get. So what
Right.
about women? Are there any women who are not good candidates for bioidenticals or hormone replacement therapy? What do they do?
So that's always tough because in the conventional cancer world, somebody would say, well, you've had cancer, you should not be doing hormones, right? So in the conventional cancer world, that's a difficult line to cross. And yet the studies don't support it. I mean, um, the there's I've lists of studies to support that appropriately done hormones is actually beneficial even and protective to somebody who's had cancer, even if it was an estrogen receptor or progesterone receptor positive cancer, or who has a strong family history. In fact, I would say we can appropriately do hormones to help protect that. So my answer to that is probably not. Is there a patient who should not be on hormones? But do I battle that in the conventional cancer world? If I take somebody who just got over their estrogen receptor positive cancer and put them on estrogen, their doctor is going to really be you know at my door knocking, and I've given them literature, I've tried to support it. So it becomes a little bit of a fine line to walk. So we kind of educate our patients both way, let them make the decision. I give them all the research I can to support my opinion. And I say, hey, go back to your oncologist and talk to them and let them show you their research and then, see what pans out. But if you side by side put the research, you can support that hormone replacement is beneficial even in that world of somebody who's a high risk cancer or has a previous cancer. Um, so that would be, my answers. Now, we do know one of the things I'll hear is women who have clotting disorders. So they have a genetic issue for clotting, and people say, oh, estrogen increases clot risk. That is only oral estrogen. So there's zero literature that transdermal estrogen, again, you're back to the difference in metabolism by going through the liver. So oral estrogen after liver metabolism will increase clot risk. No studies to show transdermal does that because it's the liver metabolism that causes that. So again, I would never give estrogen orally. That's the problem with birth control pills, right? It's a high dose oral estrogen, and that's why there's a high clot risk with birth control pills, that you can get blood clots and pulmonary embolus. And the other thing oral estrogens do is they deplete testosterone, because they increase sex hormone binding globulin, which binds all your total testosterone. So now you have no free testosterone benefiting you. So oral estrogens in general are contraindicated for a lot of reasons, but transdermal's not. So those are the groups I hear from their doctors. Oh, my doctor told me I can't do hormones because I had a blood clot or because I had breast cancer. And I would argue that there's literature to support that that's not true. But my big deal is I will never convince, anybody to do anything. I want you guys to make that decision. And what I will do is present the evidence. I'm an avid reader. I try to put it all together and say, hey, here's the studies, and I'm happy if your doc wants to come back and show me all their studies and change my mind. Great. It's like I was talking about, if there's a study that I'm not aware of that shows that there's the transdermal progesterone has the same brain effects, then albeit maybe I'll change my mind. But things need to be research based and not just made up because we're scared or things like that.
Yeah. And I'm sure that goes to hormonal replacement done correctly,
Right,
right?
exactly.
We're
Right.
assuming
Yeah.
that because there's plenty of studies I'm sure that could show one way or the other, but it's got to be done
Right. It's
right.
the right kind of hormones, right? Premarin is bad. Premarin is carcinogenic. So it's the right studies done with the right hormones, done at the right dosing. Using things to change metabolism.
Mhm.
Just simply, any of you who are doing hormone replacement, even if you're like, oh, I can't afford to do that, you're a metabolite test. Simply taking diindolylmethane, DIM, and or indole 3 carbinol, those are the things that are found in like broccoli and cauliflower. They're so beneficial to our health. So the way they work is they're actually, remember that 4-hydroxy pathway we talked about? Well, DIM is a great blocker of the 4-hydroxy pathway. So if you're taking estrogen and taking DIM, you're going to hopefully drive less down that pathway. So anybody who's on, number one, I think just about every woman should be on DIM, and maybe man. But that's a good thing to think about too, is, there's ways to kind of do the hormones more safely, even if you're not going to go down the road of, you just can't do all this urine metabolite testing. It's ridiculous. At least you can do things that will likely ensure more protective effects.
Mm. So I have this just reminds me, when you talk about DIM and then I talked about the progesterone cream, and people may be listening to these podcasts, not only mine, but someone else's, and go, well, I'm just going to go and buy that progesterone cream online or buy that DIM online. What do you say to those people who are trying to self-medicate uh, without a doctor's guidance? And they said, oh, I should know because I'll feel better.
Yeah, I think that's, I think that's a place where it's sort of like, I guess I would equate it to, you're an avid traveler, right? And when you go somewhere, like I remember, and we've done tons of traveling where we've just tried to do things on our own sometimes, where you go to the Colosseum, for instance, and you're like, oh, this is cool. And then you walk out of the Colosseum, right? And if you walked in the Colosseum with this guide and they tell you all these really cool stories and they point out this rock that something really cool happened at, you know, it made such a dramatic difference. I'm like, wow, this is really cool. It's not just this big arena that's like kind of neat. Everything becomes so much more interesting and better. Well, the same thing's true about taking care of your own health in one sense. There's so many things you can do on your own that are very safe and effective. But if you're working with a guide, somebody like you, somebody, a physician, doesn't have to be a physician necessarily, but somebody who can kind of guide you along that path, your results and your outcome and your pleasure from the experience is going to be dramatically better. I think there's some very safe things you can do on your own. I don't think you're going to hurt yourself by taking DIM. I would say that there's a lot of sources out there. I was just reading an article that they tested. And I've seen this for Amazon, but I hadn't seen it for just the store. So it was Walgreens, Target, Costco, and 6 out of 7 supplements they tested had none of what was advertised on the supplement in it. And so you have to be very, very careful about what brands you're buying, things like that. And that's where that's where you could potentially be probably wasting money or doing harm if there's contaminants in them and things like that. But I don't think anybody's going to hurt themselves by taking DIM. I think that, are you going to hurt yourself by using a wild yam cream, which, these wild yam creams, which have been touted as progesterone, derivatives. And indeed they are. The problem is it's in such a low amount that your likelihood of getting a significant benefit is, probably very, very small, if at all. And
Mm.
so, but do I think you're going to hurt yourself by using them? I mean, probably not. But much like walking to the Coliseum, where you're like, well, it's a big
Yeah.
rock. You know, you're just not going to probably see the benefits. And then you're going to say, well, I tried that, didn't work. Instead of having somebody who can really work with you and refine things, it's just having a tour guide, having somebody along your side. Like I said, I don't know that it has to be a physician all the time. I think if you're doing hormones, you have to obviously have a physician behind you, but there's like some of these natural things. I think that people like you and, Natalie and people who are so incredibly knowledgeable as guides can be so incredibly helpful.
That's good. That's good to hear. I was worried it was going to be worse. So we're wrapping up with the time, and I want to give people as well moments to ask their own questions. But before we go on, how would you recommend women best educate themselves on hormones in general?
Read. We try. So it's one of the reasons we put together our Human Optimization Academy, and one of the courses that's up there is what's called What to Fix First. And so if you and it talks a lot about hormones and how do I just start to take control of my health, and then I have talks up there talking about this subject about hormones and cancer, hormones and athletic performance, which is a huge thing we didn't even get into. We should do a whole thing about that. How do you utilize hormones to increase athletic performance and to prevent injuries? And so I think that that's a great source. We're trying to, like I said, I try to base everything. My goal is to teach people the way physicians should be taught, and that is off of research, right? We should look at the research, critically look at the research, because there's a lot of bad research. So my goal is to take all this research that's coming in, critically look at the studies, pick out the good studies, and hopefully digest them and give them back to you guys and say, hey, okay, here's the research, here's the evidence, here's my thoughts, but read the research and figure it out. And so you've got to look for these curated sources of that. So I think that that's one of the best ways to educate yourself is to, is like our Human Optimization Academy. I think listening to podcasts like you have, those kinds of things are huge. There's a great book called Estrogen Matters. That's a really helpful read written by an oncologist and an OB-GYN that really sort of will reassure you a little bit along that cancer front. So I love that book. My friend Uzi Rice, who's a big, huge hormone doc in LA, has written several books on estrogen. Dr. Rice, Reiss, has written several really good books on hormone replacement. He's brilliant in the subject. And so I think, read, and if you're overwhelmed by the reading, it's what I think, our goal as physicians should be. I mean, physician, the word means teacher. That just got lost along the way. So that's really what my hope is, and is that I've tried to take this stuff, put it together, try and make it digestible, present it to you, and then do what you want with it. I'm never going to force anybody to say my way's right, or this, you have to do this, but read and
Yes,
learn.
absolutely. Educating yourself anyway is better. And I appreciate the book recommendations. And I signed up for the Human Optimization Academy, and I do remember that first things first. And I have to get back to it because I just let it go by. So can I go back, or is it do I
Yeah,
have
no, I
a
think once you, no, I think you have access
period?
to it. It's, yeah, you just go back and
And it was
watch it over
so
and over again.
affordable.
Because I talk so fast that you
Yeah.
have to listen 4 times.
It was great. No, I feel good because I can go back because I had let it go and summer came and really want to go back to it. And I remember it being so affordable. I was like, this is a no
No, guys,
brainer.
it's like, I mean, it's an inexpensive little course, but we put it together because we had so many people who are like just paralyzed by the amount of information. And we said, okay, here, start here. Look at your hormones. Look at this, just to give people a little bit of here's where to start, because I think all this information too becomes so overwhelming that you get paralyzed with information, information paralysis, and people just then don't do anything because they're paralyzed with information. So that's why we kind of put that together, and that's why we're trying to, and I have a lot of talks in there on uh, joints and hormones, and and so just go peruse the stuff that's there, and and have access to. There's a lot of free access on there, and there's some that's paid.
So much stuff. So much stuff. It's BLI.academy.
Academy,
That's what it is. BLI for the Bulger Longevity
Academy
Institute
Institute, yeah.
Academy.
And then we
Go
always,
check it out.
we see people all over the world, because the good thing about COVID is it allowed us to really all get really good at this, or pretty good.
Yes.
We still screw up our microphone sound, but So
exactly.
half the time where I'm like, God damn it, what did I do wrong? But the so I think that the nice thing is we're always happy to do consults. I have myself and I have two PAs, one who really is my peptide guru, and so we're always happy to help and answer questions too. So you guys always have access. But there's so much you can do on your own
Mm.
too. Just learn
I'll,
and read.
I'll, yeah, I will definitely put the links in the show notes, and everywhere you will find easily find Dr. Yurth, as well as the Academy. And if you have any questions, you are so accessible. It's amazing what you're doing. Before I move on to the panel, I just have one last question, because you mentioned peptides, and I can see you are so fit. You've got muscles, and you're in your 50s, right?
60. Yeah.
What? 60? Oh my God. Well, you certainly have been able to keep up with the muscle mass. What is your secret? Is it hormones? Is it peptides? Is it combination? Is it training?
Yeah,
Food?
I think, a lot of it is certainly training. So yeah, like I said, exercise is certainly key. I'm a avid. I mean, I do not miss a workout. Um, I lift a lot of weights and, so I think weightlifting becomes key. But could you do that without having and I don't do tons of hormones, but I do some, right? I do enough to balance them out. I'm not, and I waffle around on peptides. I love peptides. There's some I stay on all the time because I have bad joints, because I didn't know this stuff when I was in my 20s. I have bad joints, so I'm always taking Pentacin and BPC and things like that will help keep my joints going, because those are probably my weakest point is my knees. And and so but then I'm always kind of cycling things around a little bit too. And I think that that's kind of an important piece. I think I do that with my training. It was funny. I was, like my workout partner and I was saying, we rarely are doing the same exercise over and over and over again, because body adapts very fast to things. And so you've got to change things up. You've got to trick your body. So changing your routines is really, really important. But that's true too with your supplements and your peptides as well, is that when you're just statically staying on something all the time, and there's things that are baseline, CJC and ipamorelin, keeping growth hormone up, but otherwise cycling around things. And that's true with your supplements. You using them for a little while, backing down a little bit, tuning this up. That makes a big difference. And that's where I was talking about having a guide to do things can be really, really helpful. But I would encourage you guys who are all just taking, open your 50 bottles a day of supplements, that explore, doing things, looking at the things that are really sort of build up, and then the things that are more autophagy inducing, and kind of start working with build up phases, breakdown phases, build up phases, breakdown phases, because our bodies are designed not to be in static states. They're designed to be constantly challenged with something else. So I think that that's probably one of the keys I think really oftentimes gets overlooked, is to not just get in these patterns and stay in these patterns. Change is good.
That is so good to hear. I just listened to Natalie Needham's interview with the HRW water, hydrogenated water. He said exactly the same thing. He's writing a book on hormesis. So having
Yeah,
that
little
hormetic
stressors,
effect.
right? Yeah, right.
Exactly. So I am going to ask the girls here. Oh, they have some questions already. Magdalena asks, are there any suggested levels of hormones for your age? What do you mean your age? In the lab, you get suggested level, but for your chronological age, oh, how high can the level be compared to younger women if you are in menopause? I'm, did you understand the question, or?
Yeah, I do.
Yeah, okay.
Yeah, so I would answer that with, that is all over the board, because I have women who, you want to be kind of in a nice little balance, right? But when you kind of look at sort of the scale of norms, um, I have women who are doing really, really, really well with relatively kind of in the low end of normal, and women who like literally just nothing's changing. They're still fat. They're still can't do anything. And I have to push those hormones up. So can you be too high? Yes. You can, but typically that's because of how things are being metabolized, right? So if metabolism is good, so you can overdo it with hormones, because too much of a thing is never good, right? But can you be on the high end? Can you? Yeah, I think that if you look at where our hormones were ideal, quite frankly, for women, very young. I mean, 16, 17, 18. That's when we were meant to have babies. That's not the world anymore, right? But so can you ideally push hormones? I mean, I think thyroid gets undertreated a lot in women because of that. If you look at really young women's thyroid levels, they're on the very, very high end, higher than sometimes what doctors would say, oh, we can't have a T3 that high. Well, if you look at young people, they actually do oftentimes have T3s that high. So I do think you have to sort of look at, we're looking at age-related norms, and our age-related norms should be we'd rather have our hormones where they were in our 20s. So that's kind of my goal, is to kind of keep the hormones at a healthy state that you were in your 20s potentially. And again, for some women, that probably was not super high. I think I'm probably not a super high estrogen person. Um, you know, but you see some of those women who look very estrogenic. They probably were always estrogenic. So Magdalena, my answer to that would be that yeah, I think that base it on not your chronologic age, but your goal age, which would be somewhere more in your 20s, and then keep, and then how you feel, right?
Does that
Um,
answer your question, Magdalena? Good.
and
Okay.
then
Yeah,
thought
there's
about
an
growth hormone to be added after 50. So here we use a lot more, and it's a little different where you guys are. In the European countries, is I think they're using more growth hormone. Growth hormone is difficult to get here. Access is difficult and expensive. But even beyond that, we use much more of the growth hormone secretagogues. So growth hormone releasing hormone and growth hormone releasing peptide. Our most common go-tos are CJC as a growth hormone releasing hormone, and ipamorelin as a growth hormone releasing peptide. The two synergistically raise growth hormone, or IGF, the best. The problem with using straight growth hormone, even though it has a very strong influence and people like it, is it sort of keeps this very steady high state of growth hormone and subsequently IGF, or insulin-like growth factor, that the growth hormone is causing to be secreted. And that overfeed of constantly on the receptors can cause some receptor burnout, which you don't see with the growth hormone secretagogues, because they surge the growth hormone. They use your own patterning, like taking them at night or taking them after workout, to get these surges. So you don't get the receptor burnout that you'll see with growth hormone with people who take it a long period of time. And what happens is people who take it for a long period of time keep up the dose, and then you start seeing this very high levels of IGF, and that will cause organomegaly. If you think about the old bodybuilders, remember how they had those little turtle-looking stomachs, really weird. The stomachs kind of protruded, and you could see the muscle, but they were really weirdly protruding out. It's because they actually had big old huge spleens and livers, because they've taken so much growth hormone that it caused growth of the organs. And you won't see that with the secretagogue. So I like the secretagogues better for that reason, beyond the fact that they're difficult to get here. I just think they're a safer way to go, and you're going to get more physiologic dosing of them. And then your last question was, levels of testosterone are in the middle of suggested ones. I don't add it on. I'm thinking now, listening to you, it'd be good to add a little. I guess it depends on your goals. I mean, I would say that if you're in the middle range and you feel good and your sex drive is great and you can have good orgasms and you feel like you can build muscle well, then you're probably fine if you're in the middle of the range. But if you feel like, my libido could be a little bit better, and I feel like I'm just not quite putting on muscle the way I would like to. My energy levels aren't great. It might not be a bad idea to push it up a little bit. So I would say, is it critical? I mean, I think that's great, because it is pretty rare to see, and it's probably because you are so fit and take such good care of yourself. But it's pretty rare to see. And I kind of look back to sort of how you looked a little bit when you were probably at your highest testosterone levels, which was like 16, 17. And if you were somebody who was a little bit kind of more on that, muscular build, then you probably, had higher testosterone levels, and that's probably more your physiologic baseline. I know you're kind of on that thinner side, so maybe that's a fine level for you. I would say that experiment with it a little bit, try a little bit and see, wow, no, I actually do feel better, because sometimes we don't know what we don't know. And sometimes just experiment when you're like, no, I hated it. And then probably you're on the right level now.
Thank you. But should it be this the cream? The cream?
Yes. Oh, testosterone and estrogen never take orally. Both of them dangerous orally. Testosterone actually has very liver toxic taken orally, so both should be transdermal creams. That's why you can play with little tiny doses of it. Honestly, like you can dose testosterone at a very small dose, and you're like, yeah, I just feel a little better.
Yeah, I would like to try.
Yeah.
Because of the muscles. We
Yeah.
are getting older, and we see the
It's
difference.
just harder, right?
Little by
You go
little.
work out and you start losing strength. I want to go to the gym and still be able to lift the same weight as my 20-year-old daughter. So so I think that's probably a big place. And remember, muscle mass, not getting sarcopenic, not losing muscle as we age, you're going to find that more and more literature is supporting that the myokines muscle produce are so important to every other organ, including our brain. So people who have more muscle have less dementia. So, it really is I think, a very overlooked organ. It's a huge organ. It's a very overlooked organ. It's producing a hormone. It's producing these myokines that doctors don't even know, exist. I got a question from one of my podcasts saying, if these myokines are so important, are they teaching it in medical school? So I actually texted one of my friends who's in Rush Medical School. And he was one of my kids who worked with me for a while. And so I said, hey, Eric, are they teaching about myokines in medical school? He goes, nah, I don't know what they are. So they're still not teaching this stuff. And yet it's critical. It's just an unfortunate truth about medicine is just not changing very rapidly. But you're going to find more and more as you read that myokines are going to be a big piece of health.
So
Myokines.
testosterone cream might be better solution than adding, let me say, growth hormone with this Pfizer pen.
Yeah, I mean, I would probably with you because you don't look particularly growth hormone deficient. And I will measure. The best way to decide about growth hormone is see what your IGF levels are, so you can measure IGF.
Yeah,
If it's So if your IGF's decent, then I would probably say try a little testosterone. It's cheaper. It's
Easier
easy to
too.
use. It's a lot easier to
here
do.
in
Right?
our
Exactly.
country,
It's a
it's not a
transdermal
problem.
cream.
It's not a
Yeah.
problem if you have a doctor, and it's also, for me, I think it's quite cheap. 100
Yeah.
euros for one pen.
Oh,
I
yeah.
think
So
it's
yeah,
a
it's a lot
pretty
cheaper
good
than here.
price. Yeah.
Yeah. Yeah. And, and you may want to do both, a little bit of growth hormone, a little bit of, of transdermal testosterone, but I think you would benefit. I think there's very few women who are getting in their 50s and on that don't benefit and feel better on testosterone.
But may I ask you, what should be, how much of testosterone? What a percentage?
So, here we kind of dose it as a sort of a milligram or gram, and and that dosing is so incredibly different, Magdalena. It's hard for me to sort of give you a dosing on that because I will have some women who I have on literally 0.25 milligrams, and some women who I have on 10 times that dose. So it's kind of all across the board. So and again, I'm not sure because the European dosing, I always get confused when I see this because it always when I have patients who have stuff from Europe for me, it's a hard time conversion because we're always doing a milligram per gram in a gel here, and things are always a little bit different there. So it's a little hard for me to comment on that.
Yeah, I will go to doctor anyway, just to get your opinion, which is very important to me. Thank you.
So does Silvina or anyone else, I mean, if you've got other questions, you can unmute if you like. I hope you enjoyed this experience. And if you don't have questions, then we will wrap up. I still have 1,000,000,001, but I know that you have to go. Oh, here's Silvina. Do you have any last minute questions?
No, I just want to say that thank you for the explanation because it was super clear. It's always very clear. Some people like go, but this is very clear. And I have to tell you, I have a friend who lives in Connecticut, and she called me like a month ago, and she said, "Oh, I need bioidenticals. I don't know. Nobody knows anything about this. So I send it to your clinic."
Thank you.
And when she called and she tried to explain how she got there, they were like, through a podcast that my friend heard.
That's good though. That's why all these people like Zora and Natalie who are spreading this word around, and you guys, I mean, it's going to be, that's what's going to change people's health ultimately, right? It's like people talking to people because we keep waiting for physicians to change.
They're not taught enough about hormones in medical school. It's just, that blows my mind, especially if you're working with women. Like how do you...
And it's funny, you had asked me a question, before the podcast and a list of questions. You said one thing is, why, you as an orthopedic physician, why, if hormones are so important in orthopedics, why don't orthopedic doctors or physical therapists or anybody talk about? Well, number one, they're all men. And number two, what's very interesting about research is that it's mostly male based. There are 0 studies for female athletes on hormones, nutrition, training around periods. There's 0 studies on women in that, just because, especially in the athletic field, men have always been sort of the, and as my boys would say, watching women play basketball, they don't enjoy anyway, but but we're still athletes, and and yet the literature is all done for men, not for women.
something's got to change. This
Yeah.
has got to change. Anyone who's listening here, please, do whatever you can to demand testing on drugs, on
Yeah, it's going to be
policies,
the
on
people, right? Like
everything.
everything, right? It's like, yeah, it's like, it's going to be people starting to be out there, saying, hey, maybe we want this, we want to look into this, we want to, and maybe it'll change. Medicine is an interesting world.
Yeah, the first
I
time I
think it
heard,
is changing little by little,
Yeah, little by little, I agree.
because
And it's
5,
because of
10
you guys,
years
right? It's
ago,
because
it
of
was
this kind of
completely
stuff, right?
different. Yeah.
Yeah, no, but I won't give the credit to the doctors on that very much. I mean, there's a few, right? I see you follow all the same people I do, and there's people out there, but there's still the small voice,
yeah, there's a great researcher at USC where I study. Her name is Berenice Benayoun, and her lab is all about testing for women versus men. And she's a wonderful advocate, and her work is brilliant to try to get people to do more studies with women. So
yeah.
I am going to let you go. I know you have to work, and I'm so grateful to have you on here. I'm really, really excited to have you now, just as a great person I can send
Yeah, I
people to
love
as
coming and
well.
talking to you.
And I hope to get you in the Energy Reboot program that's coming up soon. So you would be the perfect person to talk about hormones for our group. And I want everyone to please check out Dr. Elizabeth Yurth's website. She's on, it's a collective, the Boulder Longevity Institute. So it's the BLI.academy. Check out, so you've got courses. So it's the same website /courses. Check out the What to Fix First. I mean, really, it's a no-brainer to go and start watching those videos. You will learn so much. And if you have questions, you want to get more in touch, you can also reach her on Instagram at Dr. Yurth, DR, and then YURTH, or at Boulder Longevity Institute. They got Facebook as well, and their website, always Boulder Longevity Institute. So thank you so much for your time.
Thank you,
so
Zora.
grateful. Have a
Thanks for all you
wonderful
do.
day.
Thank you guys for listening.
Thank
Bye.
you really so much.
Bye.
Bye.